My name is Caleb Staggs. I'm a paramedic for Lawrence County EMS, and today we're going to be talking about underutilization of providers in a ground EMS setting. Um, a little disclaimer, these views, topics, and opinions are all my own and do not reflect on my service or any other administration or providers. Little overview. We're going to be talking about things that we do well, things that we can improve on. We're going to touch on trainings and competencies as well as protocols and procedures, talk a little bit about provider discretion and also ground versus air. So some things that we do well, we've got cardiac and ACLS care. So this goes everything from just a chest pain, NSTEMI, tachycardia, SVT, um, all of our arrhythmias, all the way to cardiac arrest, things of that nature. It's something that in school we're taught very much, something that with our competencies, usually mega code is one of those things that gets covered. We also got airway and respiratory management, and this goes everything from your asthma, your COPD, all the way to respiratory failure, respiratory arrest. Also kind of encompasses overdoses, just any kind of airway management that we do pre-hospital with something that we can provide. Stroke recognition, as far as the standpoint of, is this a stroke? Is this hypoglycemia? Is this some other illness causing them to present this way? As far as between discerning, is this an ischemic stroke? Is this hemorrhagic? Is this something like a small vessel, a large vessel, things of that nature? It's covered very well in schools and competencies. It's something that most of the time trainings cover. It's something that just as a ground EMS provider and even a air medical provider, I feel we do these very well. NCI and triage is our final thing. This kind of encompasses your car wrecks, obviously active shooter, mass casualty, those types of incidents. But even so, a lot of that stems from and kind of builds off of calls with hectic scenes, loss of family members, things that we have to manage, uh, calls that end up with a lot of other responders on scene, and just it's one of those things that helps to build those skills that we need. That way, when we have these true mass casualty incidents, that we have the skills needed to handle those. Some things that we can improve on, patient advocacy and complacency. So this is kind of referring to being a good patient advocate, doing what's in the best interest of your patient. For those of us in more rural counties, if we have someone that we go get them and we know that they're going to need something that our local hospital can't provide, taking them where they need to go, so long as we're within our standards and our protocols and procedures to do so. There are providers that they'll pick somebody up and they'll say, I don't really want to go right now. They'll dump them off at the local hospital, and then, it's someone else's problem later. And that's just kind of their attitude about it. It's not something that we should be doing as providers. We should be taking those patients and doing for those patients what they really need. Complacency is just it's on the same subject of that in a way, knowing, being able to know and provide the skills, having the knowledge to decide what's going on with your patient and decide where they want to go, and just making sure that you're up to date with current and active practices that are still within your protocols. Aversion to change, there are things that EMS doesn't like. Those things are the way things are and change. And we can't be that way. And we, as leaders, providers, should be trying to implement that change, trying to make us better. EMS is always asking for respect. We should be doing the things that are needed to give us that respect. And then lastly, resource availability and allocation. Uh, Obviously, we have some very well-off counties within our region and within this state and this nation that do amazing, very progressive things. But a lot of those things are also very costly. And there are a lot of rural providers in this region, in this state, and again across the nation that, they're at these more rural services or services that financially just don't have the funds or the resources to do some of these things. And how do we fix that? How do we change that? I'm not the one to answer that question, but at the end of the day, it's something that I think a lot of us as providers, and especially those of us that look outwards and at other services other than our own, trying to change, trying to improve, it's something that a lot of us can really see. So training and competencies, a lot of services tend to, you'll hear people say, "Oh, well, so and so, we have to think about this. Do we want so and so doing this thing?" And they're operating to that lowest common denominator. Uh, and that's something that, as a service and as providers taking care of our patients, we really shouldn't be looking at it that way. The way that we should be looking at it was this next point: higher standard of care by way of improved training. Uh, if we can make our providers better, then we have ways that we can improve the service that we give. We can improve our providers to improve our standard of care. Um, and the way that we do that is improve protocols, improve trainings. We have, most places have your annual, your quarterly competencies. We do CEU type lectures, learnings, classes monthly in places. Um, but the only way to say that we can do these things and we can implement these changes and use these more advanced and progressive protocols, skills, procedures is by training our providers and making them the provider that we want. As far as protocols and procedures go, one thing that we're going to look at, poor implementation of interventions. We're going to touch on this a little more on the next slide. So lack of advanced level procedures, that really just kind of tends to be, as a paramedic or even as an AMT, as an advanced level provider, are we as a service giving them the tools that they need, giving them the protocols that they need, and giving them the training that they need to make sure that when the time comes and we need to do this, that we can. Um, we're going to touch on this here. So finger thoracotomy and chest tubes, RSI, DAI, ventilators, antibiotics, blood, medication variety. So most services we have needle decompression. Um, as a paramedic provider, going through paramedic school, we're trained for finger thoracotomies. As a critical care paramedic, you are trained for chest tubes. Why are we limiting the services that we provide instead of giving them the best that our providers can offer? So if our providers can do a finger thoracotomy, a chest tube, we should, as a service, that's something that we should be looking at implementing. RSI, DAI, ventilators, it kind of falls in that same standard, that same ideal is we're limiting ourselves from the procedures and from the skills that our providers are trained to do. Antibiotics is something that a lot of services are starting to pick up more of, whether it be for sepsis or for open fractures. Um, of course, with sepsis, you have to think about cultures. So that's something that you have to kind of work around in a way that's a hurdle that we're going to have to cross. Blood initiation, there's already a wonderful service in this region that is doing this, and there are more services, especially when you look at our medical, that they have. Is it feasible for everyone? No. Are all of these feasible for every single service? No. And that's something that, also as progressive providers, we have to look at, okay, as a service, this isn't something that we can do. What changes can we make so we can start to close that gap? And then medication variety, it's kind of a multitude of things. So say you have one antihypertensive, and that would be labetalol. If we have a patient that they tell you they're allergic to labetalol or they are unresponsive to it, they've tried it before and it doesn't work for them, and they're in a hypertensive crisis, or if we have a head trauma or a hemorrhagic stroke, is labetalol going to be the best medication for that patient? And this applies to other things like seizures as well. As far as having another option, another tool that you can use to treat that patient and to provide for that patient is something that we should all be pushing for. Provider discretion, this is really kind of a short topic here. Um, whether or not we plan to use provider discretion, at the end of the day, you can't pick and choose which providers you allow to use that discretion, and you have to decide if it's something that you want to implement or not as a service and as administration within a service. And at the end of the day, is discretion good? Can it be bad? It absolutely can. And that's something that, as lead providers, we kind of have to look at. The last thing that we're going to touch on is ground versus air providers. Personally, being working in a rural community, working at a rural service, if we have a patient that needs level one trauma services, they need, you know, interventional neurological services, whether it be from a hemorrhagic stroke or whatever the case, those patients are going to be transported a long way. From Lawrenceburg to Nashville, you are looking at an hour and 15 minutes to an hour and 30, sometimes even more, depending on conditions, what time you go, traffic, weather. And our medical providers, you're looking at around 25 to 30 minutes, depending on, again, weather, destination, things of that nature. Um, the transport times, and it's not this way for every county, and there are definitely counties that have much further to travel. But these counties especially are looking at what things can I do for my patient, what things does my patient need, and what other resources can I call upon to give that patient what they need. And a lot of times that ends with our medical. Um, you know, at the end of the day, we may ask ourselves, if I could have given that patient a chest tube, if I could have given that patient blood, if I could have given that patient whatever it may be, whether it be something like mannitol, whether it be a different antihypertensive, whatever the case may be, a lot of times we end up limiting ourselves by what we can't do. And at the end of the day, our medical services can provide a lot of that, a lot of those interventions, a lot of those medications, and they do have a lot of that skill set. Um, does ground EMS need this more than than our air medical providers? Possibly, if you want to look at it that way. You have to look at your resources, you have to look at what you have available to you, and you have to utilize that to the best that you can. Everyone's limited in some way, shape, or form, and not every service has the ability to do the things that they need to do or want to do. If our ground providers had access to some of these more advanced skills, some of these more advanced interventions, medications, whatever it may be, could they benefit that patient better? Um, so that's all I have for you today. It's just something to think about, and I hope you enjoyed.